improve healthcare systems by promoting communication between providers, and this again, can be not only within the same hospital, but across hospitals across the country. And it can also capture quality measures, so in an easy way, an easier way, to capture specific diagnostics or treatment trends, infectious disease rates, or immunization rates. So algorithmically, this is what it could look like. First, the patient is identified, so you need to have a patient identification system in some way. Often there's a medical record number or a patient identification number. And that begins the medical record. Then they go to the emergency department, to the ward, to the clinic, and the record begins. Consultation notes and surgical procedures can be added, pathology reports, radiology reports, can be added, and then the patient is discharged. That note ends, goes to the computer, and then the patient presents to that hospital or another clinic. That record can be reopened, and we know what happened with that past encounter. So it's a way to provide continuity of care and keep track of it. For those of you who don't know where Maine is, the United States on the left, and on the right, in the very top northeast corner, to the right upper corner, that's Maine. So we're surrounded by Canada, Atlantic Ocean, and the border of New Hampshire. And Portland is down the lower portion of Maine. Again, Maine Medical Center, we're a 600-bed tertiary care center, a teaching hospital. We're part of a 7-hospital system, meaning we have a parent company that also is affiliated with 6 other hospitals in the area. That's key because our newest version of electronic health record was rolled out 20 months rollout. It started 2 years ago. And the purpose of that was actually to connect all of those hospitals. So the patient, one hospital with a problem 3 years ago, before I even walk in the room, I can fill up that chart and know demographics, everything about that patient that I want to know. Now, I think it's important to mention something about how this came to be financially, because, of course, one of the problems with electronic health records is cost. The government actually, the U.S. government has supported financially, they've incentivized hospitals to do this, to actually have electronic health records. In 2009, President Obama signed the American name, age, their chief complaint, and who's taking care of them. And then this was tracked whether the patient being admitted to who, or being discharged. We also then developed an order entry system. So this is an electronic order entry system. So if I wanted to order any labs, radiology, or any medicines, we can do it electronically. I can send via computer to each of those departments, and the results come back for the medicine we were sent to us. Now this was eventually incorporated into one larger EHR that incorporated everything. This was one-stop shopping. This was a way to track patients, but also a way to admit, discharge patients, prescribe medications, order, tests, see results. So this is an example of the things that we would order from laboratory studies, urinalysis, we can read that, and CT scans and X-ray. Later, I can press on the results button and see all of those labs and urinalysis. I can also look and see all of those past results if I look back in the patient's chart and compare where they've been in the past year or 2 years further. On the right, and the radiology report for a CT scan, so I can look and see the radiologist's report in the CT scan. Just an example of looking at documentation. The last piece I wanted to mention was order set. Electronic health records often offer a way to standardize treatment for patients by creating order sets. Evidence-based orders for a specific diagnosis. So this is an example of actually a sexual assault order set. So by following our national guidelines for how we should be treating sexual assault patients, the order set pops up and we're going to order the right things for our patients. So just summarize here, I would consider the pros for electronic health records as it increases efficiency, improves accuracy and quality data reporting. It can prevent repetitive diagnostics, ensure accurate medication, and prevent medication reactions, and has easy access to past history. It also has opportunities for provider patient education that can be linked to online resources such as journals. Another pro I would consider is encouraging more uniform evidence-based practice, as mentioned by the order set. Cons, change can be difficult. Of course, physicians have a hard time with change, especially computers crash, so we need IT support. the administrative support. This is not a ground-up movement. This is something that needs to come really from administration as we need financial support as well as IT support. So I think we're running out of time, so I'll end there. Thank you again for your time and your attention.
Great. Thank you very much, Carl, for your nice presentation on how we work in the Open Information System in monitoring and surveillance of HP and SDP.
Thank you for the opportunity. Ladies and gentlemen, good afternoon. The title of my presentation is Role and Scope of the National Information System in Monitoring and Surveillance Systems of HPNST. During the next 10 minutes, I will try to provide you information on the current status of the MIS in monitoring the health sector program in Bangladesh and its future scope. Health, Population and Nutrition Sector Program, HPNST, is the third consecutive health sector program that marks a shift from multiple project approach into a single sector-wide approach which is called SWAP in Bangladesh's HND sector. From the table, you can clearly see that over the years, the size of the SWAP has increased substantially and the government's contribution is centered. I will start the presentation by providing a brief description of the structure of the health services delivery in the public sector in Bangladesh. The numbers should be updated because I'm still using for the sources of MIS 2010. Starting from the central level, health facilities are available after the grassroots level, with 100 clinics for every 6 to 8,000 population in rural Bangladesh. In addition to MIS, routine information on public facility-based service conduct in the lowest 4 tiers are currently being collected through 3 separate MIS entities: the HRS as a digital services, the MIS in the family planning, and the community MIS. However, there have been activities going on at this moment to bring especially the community MIS and the HRS as a HRS with a closer collaboration. Moreover, this diagram, HRS operational plan, MIS in the family planning, IMCI, EPI, EPI is the control program, and lastly, the urban primary healthcare project, with the aim of consolidating data at the central level from different programs at some point of time. A number of initiatives currently are ongoing to streamline routine health information system in the central program. A team of experts are working under the leadership of the MIS in digital services and is working with both the MIS unit and creative operational plan in order to make the routine data collection process more efficient. I will now focus on the second part of the presentation, namely the scope of MIS in monitoring the health of Bangladesh. The policy options outlined in this section should not be confined within the HPNST only, but for future swaps as well. I will start. Before starting the section, let's focus on the building blocks of the health information system. Of these building blocks, information system is an integral part of the health system activities that has a direct impact on the overall health sector, particularly on responsiveness and improved efficiency. An information system that relies on and uses routine data sources is particularly important for sector programs and we focus on improving the effectiveness of the development activities. Without reliable routine health information, it is not possible to demonstrate any impact of the donor investment in the health sector. Rather than relying on structural reform, the government as well as the development partners across the countries are jointly using result-based budgeting and monitoring to process and output indicators for managing reform. So, what needs to be done in order to collect data from the households on a regular basis or to segregate health systems across the major parts of the country or even exploring multi-site health and emergency surveillance system, putting at least at the digital level. And all of those possible options would be to collect community data on a regular basis. In order to ensure coverage and timely processing of information, data collection through mobile devices like smartphones, PDAs, and tablets should be explored. By using routine data to address some of the known system issues like vacancy, health and injury can be made a part of the application process. Collaboration with private sectors to strengthen monitoring and surveillance as and when required can be explored. Coordination with other government and government activities like sample validation systems by DBS and other national projects we strengthen the validation process as well as we prove to be beneficial for all the actors in the sector. Lastly, putting the effective computer process through routine process will increase data use from the existing MISs and hence will improve their capacity in the long run. Under the current practice, expenditure against ADT allocation is primarily used for reading progress of the operational plan under the HDMI. And at this moment, we are working together under the leadership of HRA and Regional Operational Plan with the aim that this program lifespan, the MIS will also play a similar role in monitoring and implementation progress. With this, I want to presentation. Thank you.
Thank you very much. Different ideas shared this time. We thought we were seeing the visual here was a little change at the time. Anyway, let's see what he has to say on that. Thank you.
Distinguished participants, ladies and gentlemen, I'm going to talk on the use of MIS data to order GIS application to improve the resources and in Bangladesh. In the picture, you can see one of our field staff counting in a GPS coordinate in front of a community building. And the data that I'm going to present here came from an assessment of the health facility for Australia and human care services that we conducted in 2012, covering all the health facilities in 24 districts. Probably many of you know about the National Neonatal Health Intervention Program of the government that is jointly being implemented with the UN agencies for exploring progress in NDG 4 and 5. So, the program was initiated in 2006 with 4 districts and later on expanded to 7 districts. So we covered all the 11 districts of the MNHI program, and in addition to these, we included 13 UNDA districts, that is the United Nations Development Assistance Framework, through that process identified low-performing districts. This is 30 low-performing districts from the UNDA district, so we have selected for this assessment, and our assessment covered about 1/3 of the total population and almost equal proportion of the total land area of the country. So these are the percentages of coverage of the health facilities in the health facility assessment that we conducted. In the right-hand side, you can see the total number of health facilities in public, private, and individual sectors by type. And we covered over almost 99% of all the health facilities through this assessment, and that included from medical college hospitals to community clinics in the public sector. And you can see that we covered over 4,000 community clinics, and over 99% of them were assessed, and 15% of the community clinics were thoroughly assessed for their health capacity to offer MNHCR services, and for the rest, a immediate assessment was conducted along with the collection of the GPS coordinates. We identified 90 private non-profit facilities and about 500 private for-profit facilities, and over 95% of those facilities were successfully addressed for this assessment. And in this assessment, we tried to cover the major areas of the health system that includes the infrastructure facilities, human resources, provision of obstetric and human care services, services district, and also the referral systems. And in my presentation, I will mainly focus on the referral information that has been collected. And I would like to mention that in this assessment we used the AMGB tools, that is Averting National Debt and Disability tools. These are the generic tools originally developed by the Columbia University based in the US, and we adapted and contextualized the AMGB tools for different types of adult facilities for this assessment. And in this assessment, we also have a GIS component, and you can see the major components that are developed. In the private sector, only about 30% of the private facilities record at least one patient in last 3 months, but the rate is relatively higher for the private non-profit sector. For the newborn complication, the pattern is almost similar, but the rates are lower. And this figure shows the mean number of patients referred from a health facility in the last 3 months. You can say that in the district hospital, in last 3 months, on an average, 40 patients were referred for mental complication, and number drastically goes down when it for the Upazila Health Complex and CWCs, and the number of patients referred from union and community level facilities is almost negligible. And surprisingly, from the private public sector, also few patients have been reported to be referred in the last 3 months. And this slide shows the place of referral. The first one for mental complication, and the name on the bottom of each of the bar shows the district from where the referral was made, and the region shows in which facility the patients were referred. You can see, if you look at the leftmost bar in the top slide, upper slide, from the district hospital, majority 100% of the cases were referred to the Medical College Hospital. And from MCWC and USC, you can see that majority of the patients were referred either to the Medical College or district hospital. And from union and community level facilities, the patients were referred to the upper level of public facilities. And interestingly, from the public and from the private public and private non-profit facilities, the patients were referred to the public sector. And the proportion of facilities mainly registered for referring patients, we can see that community level facilities, in the community level facilities, maintenance of referral and maintenance of register for referral is very poor. And when inquired about the use of the referral slip, then we found that the practice was also extremely poor in the union and the community level facilities. And I think I have only a few moments left, so already time is finished. So I'm not sure whether I can continue for 1 or 2 minutes or 5 minutes. Otherwise, I will have to stop. 1 minute? Okay. And the practice of maintaining referral register for using referral slips is much low in the private and below level public facilities. So my recommendations are the training and support supervision of the healthcare providers and leaders for improvement of their referral practice, and the private sector also should be oriented to comply with the standard procedures for using registers and slips for referral. Implementation of the web-based GIS application by using MIS and the health system data will help instant identification of the problem and give feedback to the student and the referral system. Thank you very much.
To identify the different health facilities across the country. Now to the next presentation, Dr. Wahida Khanum, please.
So now I'm going to talk on the effective referral system to managing information system in Bangladesh and what is the role of health protection. Few slides on the effective referral system, and next I'm going to talk on the health information system and e-health services and strengthening the referral system to MIS and the role of health protection. As the referral system is a process which ensures the accessibility to high level of medical care to the patient from the community or primary level healthcare facilities. The improved quality of hospital services is an important element of making the referral system effective. And healthcare professionals should play the key role for an effective referral. So what is the importance of an effective referral? The presence of well-established referral system is important for proper functioning of the health system based on the primary health care. And the adequate and well-functioning referral mechanism is essential to provide the support to the essential service delivery package. And it can help to provide the efficient, effective, affordable, and equitable services to their community. And it can help the referral center to treat the referred patients without much delay. So the referral center might reduce the bulk of the patient and patient load and can provide a specialized services with development of an effective referral system. And the patient can also get the appropriate healthcare services they needed at ease. So we have the very structured healthcare facilities, the primary level care from community clinics and up to the Upajala health centers, that is the healthcare services delivered at the sub-district level and on the secondary care level and the tertiary care center. So the effective referral system, this should be bidirectional, not only the upward referral or not only the downward referral. So upward referral is necessary when there is serious and complicated cases from primary care to secondary or tertiary care. And when even the downward referral is necessary by periodic expert opinion and expert consultation from either secondary or tertiary center to the primary care center. If we can arrange this downward referral also, so it would be more cost effective. Referral system is a major challenge for health services. So what are the key factors to be considered? And it is already told by my first speaker. So again, I am highlighting the development of streamline of the referral procedure and development of referral protocols and referral cards. So this is a very important, these points are very important for development of effective referral linkage between the health facilities. So the health information system as we health, we have already heard that the health population nutrition and the national Vision 2021 call for timely and evidence-based decision making supported by the health information system and quick service delivery through ICT for creating citizens universal access to the healthcare. And the National ICT Policy 2009 emphasized on digital health and physical statistics, key deliverables for Ministry of Health and Family Welfare. And this is the MIS digital, we know that. And this is the inauguration of the health information system and health services of MIS in March 2010 by our Honorable Prime Minister and the session, chairperson of this session is describing nicely the social program. So the effective referral needs clear communication to ensure that patient service should be optimum at each level, and healthcare professionals should play the key role for effective referral by using MIS, health and e-health services between different healthcare levels. Thank you all for taking.